All right, we're going to go into our next section here. Page 84. And this general medical section actually has several small sections in it, and these are all from the blueprint. We just call it general medical, or I guess like in Jeopardy, it's the potpourri category. We're talking about some blood conditions, bleeding disorders, electrolytes, fluids, infectious disease. I think that's most of it. So we'll start with anemia, which is the first concept. It's nothing you need to memorize the number about. You just need to know anemia means you have less red blood cells to carry oxygen, less hemoglobin is there. Okay? You be anemic for one of two reasons. Either you don't produce enough or you've lost it. In the ER setting, most of our patients will be acutely anemic from acute blood loss anemia. So our trauma patients. We're not going to have to worry about chronic anemia, that's a different story. That's not an emergency call. People are chronically anemic, they adapt to that over years. We're talking about acute anemia, that's a concern to us as ER providers. And so most commonly we have to deal with placing blood products. ITP, idiopathic means there's no consistent cause. Thrombocytopenia means low platelets. Purpura is just the rash you may see on the skin, which basically is small bruises because they don't have the platelets just to heal up even minor skin trauma, minor surface trauma. Okay. This patient, their wrist was bleeding, they don't have enough platelets. So what do we do for them in the ER setting? We basically try to avoid, invasive procedures, additional arterial sticks, excessive IV starts, things like that. Try to minimize risk for bleeding complications. This patient would only have this on the exam. Would only have this condition as part of their history. They're not going to come in with, and you make the diagnosis right off the bat. They'll come in like they're injured, and they say, "Hey, I have ITP. I'm supposed to come see you when I get an injury because I know that I'll have this hematoma just one quick and larger case." So they're going to have some findings of that bleeding on the skin surface most commonly. Of course, when I handle the patients gently, there'll be body slamming and things like that. Now, even though idiopathic means no consistent cause, some patients do have a known cause. Some people it's an autoimmune issue. Some people it's their spleen. Your spleen basically recycles your red blood cells, it breaks them down, and recycles them to be formed again. And some ITP patients, the spleen hangs on to their platelets too often, keeps too many of them there, so they're not circulating. And so those patients, if that's their cause, they have a splenectomy, and that moves their platelet count up sometimes. But again, each one has a different cause. An exam wanted to ask you a possible treatment or consideration. They would tell you what their cause is. So if it's an autoimmune cause, you're towards things like steroids. If it says their spleens down to be enlarged, they're probably going to get it for splenectomy, that kind of situation. We're talking about DIC. DIC is not an ER problem, right? Say yes, please. If they're going to DIC to ER, they're too long, right? And this does not happen in minutes. It happens in several hours, maybe 24 hours kind of thing. But we need to know about it as ER people to understand our patients may be at risk for it, to start doing things early on in their care, like trending certain lab tests, being aware of who's at risk and who's not, so we can transfer for care handoffs or communicate these things. So we're going to have just a basic understanding. And so I'll leave the rest of the morning, let you guys try to write all that down. That's way too complex. That's a little bit better, but it's still confusing to most of us. So we'll make it really, really simple. We'll use this. This is something I drew myself. It's in the back of your book where there's some pictures and graphics in the back. It's also back there. Or you can just write down these 6 bullet points basically talk through it. And these are the 6 basics we're going to want to know about this for the test. The first big concept is it has to be some systemic underlying insult to start this situation to trigger. So we're talking things like trauma, sepsis, crush injuries, massive bleeding, something systemic, a serious insult to the entire organ system. You're not going to go to DIC if you're stubbing your toe. Okay? If you've got crushed by a car, you're still alive, that kind of situation. Right? So some systemic underlying problem. In the organ system in our body, each cell has been affected. The cell wall has been damaged, sends out signals saying, hey, come heal me. Hey, come do something to fix me, I'm damaged. Okay? And there's bleeding at the microvascular, microcellular, very teeny tiny level. It's not visible. So the body responds as it should. It sends out precursors to clotting until his damaged areas start to stop the damage, to start to plug up the diaphragm, to start to plug the leaks, if you will. The thing is, it's a systemic response. It has to go to all these tissues, and it basically is going to run out of clotting factors. It's not going to have enough. I mean, we'll make more eventually, but the initial component, the initial amount that we have on standby, it gets consumed rapidly. Okay. Now, some of the tissues in the body aren't damaged. They don't need platelets and clots to form on them. So let's say that my kidneys were not damaged. The thing is, this is a systemic response. The body's just dumping these out to everywhere. So there's clotting factors going to my kidneys that don't need to be there. On a normal day, my body deals with this. All right, that's like when we talk about DVT. We don't give you thrombolytics for DVT. We give you Coumadin to prevent it from getting bigger and creating more clots, but your body has enzymes that degrade clots all by itself. All right. In this setting, though, so much of this clotting factor goes to so many areas that don't need it. We can't deal with that. Our body can't reverse that, and so organs end up starting to fail because they're having clots put in them that don't need to have clots put in them. So even though DIC, we talk about how patients bleed out to death, and we hear all these horror stories about how much blood they had to give them, like in the ICU or whatever. That's not what they die from. They die from is organ failure, from clots being in functional organs that don't need to be there. We can replace these blood clots all day long, giving them blood bank big enough, and giving them follow numbers which are really good the right percentages. But it's the organs when they fail with clots that kills the patient. Right? So that's what they actually die from, thrombosis and organ failure. That being said, even though you give a bunch of blood, don't look in the book. What medicine are going to use to save their life and keep their organs from clotting off? Heparin, which seems bizarre because all you do in DIC is the patient's bleeding out. Why the hell am I giving them heparin? We're giving them heparin to try and salvage the organs that are functional that need to be saved. Okay? You don't need to know the dose, you don't need to know the amounts or how often, things like that. Just know heparin is the medicine we use for DIC in addition to blood products. So looking at the labs, obviously you're going to see the platelets be low on your hemogram or your CBC. You'll see the thrombocytopenia because the platelets are being basically consumed, used up faster than they can use. You're going to see, of course, the INR going up, okay, as we become more and more risk for free bleeding. Now, fibrinogen isn't the standard lab thing you're going to do, but when we think about the IC, if we think the patient's at risk, we may add it on as a baseline and start trending. You don't know what fibrinogen is. It sounds like something to do with fibrin or clots. At least it has something to do with clotting. So obviously that's going to be low also. Now the first two, the CBC and the INR, those are in most places trauma panels for your trauma patients anyway. So you already have those as a baseline. Because you know, the INR, we always got trauma patients going to surgery, or they're on medicine like Coumadin, increasing their bleeding time, things like that. So we always want to know that. So those are standard. Fibrinogen we usually can add on. We might do an ICU admission, or if they start to worry about going to the ICU. So heparin is the drug of choice. We're going to save those organs from clots and preserve them. And basically, we got to wait out the damage and wait for the body to start to heal itself. So it's just a matter of buying time. It's blood and heparin. All right, so that was DIC, like 5 minutes. Very short. All right, hemophilia, another bleeding disorder like ITP. In this case, it's not the platelets, but it's the clotting factors are deficient. There's 4 or 5 out of which main types in the U.S. The nice thing about them is the name of their disease type is the name of the factor they're deficient in. So it's a factor 10 patient, guess what they get? Factor 10 replacement. Okay, makes it a little easy. Of all of the predominant types in the U.S., there's only one unique type, that's a factor 8, that can treat at home and start self-administering. It's by sub-Q injections of the clotting factor early, hopefully to stop the bleeding episode. So say they're out playing soccer or something, that kicked in the shin, have this hematoma that's starting there, a bruise or blood collection. They can administer at home, maybe it'll slow it down. There's no question about it. They have to come in. All I can tell you, the unique thing is that they may be able to start administering medicine at home, but that's the only one that's factor 8. And obviously, if they have significant injuries like head injuries, we have to scan their heads. We got to treat them just like they're on Coumadin basically. Okay, so even minor injuries for hemophiliacs become more serious, more involved workup sometimes. And of course, we'll treat them like the ITP patients, also try to minimize punctures, other trauma, other arterial sticks, things like that, or under our care there. So there's the statement about factor 8, maybe is the only one that may, and not all of them do, but If the test question says the patient has hemophilia, they come for evaluation, or you started treatment at home, what type are they? You're going to say factor influences. Sickle cell disease, sickle cell crisis. Again, the nice thing is no drug seekers here. I mean, real patients, your real crisis. It's a disease that triggers, something triggers the sickle cell process. Those cells just start to sickle and assume that atypical shape. And when they're that atypical shape, they don't carry oxygen because it can't lock onto the same carrier molecule, the same carrier site that it normally would. So it's basically ineffective red blood cell. So they can be relatively hypotoxic. We look at their blood tests or be anemic because those atypical cells aren't showing up as far as red blood cells, red blood counts, etc. Remember, they have chronic anemia. Okay, so we don't get all excited and and the damn time I ask about they have a hemoglobin of 8, what do you do with 7? They probably live at 8 or 9 anyways. They've adapted to that. Okay. This disease and triggers, common triggers of sickle cell, simple things, dehydration, stress, illness, simple things. Trigger that episode to start. Pain, once it starts, becomes a continual trigger, so we must address the pain as well. We can address the other things, we can rehydrate them, whatever. If we never address the pain component, then that trigger just keeps happening basically. So on this exam, it's really nice about drug seekers. We do treat the pain, we treat it aggressively, we want to get it down to an acceptable low level with the patient here. Oxygen is not going to be the ideal thing in the emergency setting. Typically, by the time they present a crisis, the supplemental oxygen is not going to make a difference. Oxygen works if it's given very early in the episode. I'm not saying don't do it, I'm just saying don't put on a non-rebreather and assume that's going to fix them. We still have to do other things like the IV fluids and search out causes and other triggers. Just don't rely on oxygen by itself to make a difference. We're looking for 2 big complications with sickle cell. All right, these things are like game changers. We're looking for the acute chest syndrome, which is basically sickle cells with pulmonary bed causing pulmonary infarcts, or potential cause, and the acute abdomen causing possible mesenteric infarcts, or mesenteric ischemia. Those are the 2 big things we're really worried about. Where do most sickle cell crises happen on body parts? Usually joints. Okay, so right off the bat, we're not having chest pain or belly pain. We're already off the hook as far as those 2 complications go. If they are having chest pain, a lot of times it's actually back pain they're describing as chest pain. So on further history, you can kind of clarify that. If it is a true chest pain, though, all I need to rule out the acute chest is a chest X-ray. If there's no infiltrates there or no haziness, where pulmonary infarcts would show up, then we're fine. As far as the abdomen, I'm going to tell you, do not miss a mesenteric ischemia. That's one of those disproportionate pain scenarios. Okay, and a very acute abdomen type of examination. All right, so basically these complications are pretty rare. They're pretty easy to pick up on. Most of it's joint pain. All right, treatment, IV fluids. Pick your pain medicine choice. Pick your opiate. It doesn't matter. That's not really the test question about this. It's more like about causes and really districts do IV fluids. One of their maintenance medicines is hydroxyurea. Some patients, their sickle cell disease responds to this as far as maintenance to keep attacks less likely. In this case, hydroxyurea, it blunts or it elevates the threshold for the sickle cell, for those cells to start to sickle, so it makes it less likely or less often to happen. And hydroxyurea also stimulates fetal hemoglobin production, which you still have the recipe for as an adult, but you don't make it unless you don't need it. This forces you to kick some of that out, which increases your oxygen capacity. So we want to see this medicine on some of these sickle cell patients, one of their maintenance medicines, one of them managed well by their provider. Some childhood illnesses, most of these will be viral infections. A lot of them are reduced through vaccinations. You don't see them as much and not as common. Right, so sometimes we haven't seen these in a long time, but they are still out there. Measles, talk about measles and chickenpox. One of the big questions about measles and chickenpox is where does the rash start? Measles starts in the face, goes down to the trunk, down to the extremities, and it progresses basically like a wave. So it extends like a wave, so the entire kid is covered, and then it fades back to normal skin color. The other thing about measles that makes it different is the rash is all the same type of rash. It's all the same evolution, if you will. The lesions are all the same, okay, the same characteristics. We talk about chickenpox, we'll tell you the different stages. So we already have 2 ways to tell these 2 apart, where they start and what they look like. Complex spots are, again, pathognomonic for measles. They only occur with it, and they're not with any other condition. So the exam says the child has these white spots inside their mouth, or they say they have complex spots. You can pretty much go right to measles as far as the answer. It's not associated with anything else. And this is about the best picture I can find. It's not the ideal picture, but at least you can see there's something there on the side of the cheek there. You kind of see he has a bit of a rash around the face as well too, although it's not going the fulminant measles rash yet, but you can see how it's started there. All right. So, and most of these viral illnesses is just supportive care. It's fluids, rest, fever medicines. For this exam, there's no preference over ibuprofen versus Tylenol for kids. I know some providers have a preference. It doesn't matter, you can pick either one. They're not going to ask you which one's better. You're not going to have to dose them either. So there's two pictures of the measles rash showing you the characteristics of how they're all the same stage of presentation. They all look the same. The other characteristics here that makes it different from chickenpox, measles tend to run together a little bit. They kind of clump together in clusters, whereas chickenpox lesions are separate individual specific lesions. So that's yet another way we can tell the difference between these two. We move to mumps for just a second, then we'll go to chickenpox. Again, a viral infection. In this case, this virus prefers to go to the parotid or salivary glands under the jaw, and for whatever reason, it likes to live there and multiply. So the parotid glands get enlarged, they get swollen, they get tender. Okay, kids still going to have the same viral program, the fevers, the malaise, the lack of appetite, and things like that. And this is showing you that large swollen parotid gland. This child is going to have a symptom called trismus, which means painful mouth opening, because the muscles of the jaw, when they open the mouth or pull the jaw down, as they go through that area where that swelling is, it's very uncomfortable. So they may not even want to open their mouth wide and say, ah, in the back of your throat. So it's painful mouth opening, trismus. If it's a boy, there's the potential of mumps virus goes down to the testicles, causing mumps bronchitis. Again, because mumps doesn't happen as much as it used to, we don't see this very much. Occasionally, we'll start doing some admission orders or get the admission history of an older gentleman, and you may hear about him having testicle surgery 2 or 3 times. I've heard it. It's like the asthma says, "Do you have mumps as a kid?" He says, "Yeah." But I think all 3 of them are well into their 60s or 70s, so we just don't see it much anymore. Does anybody want to tell her? APAP, acetaminophen, ibuprofen.
One person I came in contact with mumps was an older gentleman from a different country who had never been vaccinated.
Yeah.
And he was a living like a testicular thing.
Oh, so you already had the orchitis?
So I triaged him with a testicular thing. It didn't look.
Yeah.
So triaged him with a testicular pain. I get a call the next day. I was 6 months pregnant at the time. I get a call the next day. Oh, by the way, you're getting close to mumps.
Is that something that's at risk for in utero?
I don't have my immunization.
But he already had, so he already had the orchitis, right? Okay.
Had no complaints of any
Yeah.
that
Interesting. Maybe he was just telling us, maybe he was just reporting things that was bothersome to him, the most concerning to him, you know.
Right.
Pertussis, whooping cough. Not a lot of questions on this. The only thing that makes this unique or distinctive is the progression of it. And typically, it's that on the first day or 2, this is like every kid goes to a pediatrician or the ER when they're sick. The first day or 2, it looks just like a regular cold. The distinctive whooping cough doesn't show up until several days into it. So most clinicians, if that child comes on the first day or 2, they don't make the diagnosis because they don't have a distinctive sound, that distinctive whooping cough. That's really what the test question there is, that it doesn't show up the first day. It's several days into it that they have that. And when they do, then we start thinking about the tests and swabs, etc. But that's really the testing point there, is that it's not the beginning of the illness. Chickenpox, so this is more common.
Quick question.
Yeah.
We're on your new guidelines for TCAP. What? Has a great exclamation point.
What's the sentence on top of it?
Vaccine immunity less than 12 years to guidelines.
under pertussis? Oh, yes, because we used to not, don't worry about that for the test. Remember that's because it's the acellular versus the other one. Why did I put that? No one's ever pointed that out to me in a long time. It's not gonna be on exam, I'll tell you that. Oh, for adults, it's for adults. Kids still get pertussis as part of their primary series when they're growing up. It's now what we're doing to adults. You guys, you're like the Adacel now. It's part of your tetanus. We're having to start vaccinating adults again because pertussis back. That's what that was. Okay, and when we started 5 or 7 years ago, I think. Yeah, 10 years ago we were just treating like tetanus toxoid and KNDR. Now adults are getting revaccinated for pertussis now for tetanus boosters. That's what that's about. So it was one of those ones that was eradicated basically, target vaccinations. And we used to give it also to adults a long time ago, and we stopped when we have to. Now we started doing it again. So we call it, we use the brand name Adacel at REO. You guys use the same one? Yeah, it's got to have pertussis. It used to just be a TB for our adult patients. Now we're having pertussis again. Also, that's what that was.
There was like a big grant by CDC requesting all the hospitals that if you're giving someone TB for like a laceration, give them TDAP because there's a huge rise in pertussis.
Yeah, and it's just easier just to give all adults TDAP now rather than differentiating who needs who does or what it's for. This is I think it's what everybody's doing. It's just more problem.
Yeah, it's a CDC recommendation.
I'm trying to remember why we're doing that. It seems like because we've been doing it that way for so long. I'm like, it's not a new thing anymore. It's standard. All right, so chickenpox. This is the herpes virus family. Of course, we say that to the family, they kind of freak out, right? There's one type of herpes, which is genital herpes. Herpes is just a family name. Underneath it, there's several other types. Chickenpox is one of them. Test question commonly about the contagious period. All right, you have to, all the sores have to erupt, break open, scab over. That's when they're not contagious, when they're scabbed over. So that's how it's transmitted, is through that open, moist pustule that just broke open. It's that moisture that gives off the viral particles into air, and the air carries into someone's upper airways, and that's how you get affected or infected. So it's got to be all across the board. The problem is that they are all in various stages. Some are early, some are mid-range, some are breaking open, some are crusted. You have to wait for all the lesions to go through the whole cycle and crust over. So I'm going to give you 2 pictures of chickenpox. They both show different things better than the other. This one shows best the individual lesions compared to the measles. They kind of run together. This one, they're actually separate, discrete little lesions. Every one of them, you can draw a circle around. It doesn't overlap with the next one because they arise in the pore structure in your skin. Okay. This one doesn't show a very good job in various stages, however. So I got to show you a picture of that. This one shows the various stages best. All right, you see some of the child are small, some are flat, some are starting to raise up, some are pustules. A couple around here where it's broken up and started to scab over. So various stages, we have to wait for them all over the entire life cycle of that rash presentation. So technically, they're not contagious when they're all crusted, but school ain't gonna let them come back or daycare until they're all gone. All right, the science would actually say, medicine says they're no longer contagious when crusted. School and daycare is the higher standard. And the difference between rash, measles and chickenpox starts at the center, torso. Measles started where? In the face. So that's probably in the test question there. Let's say where the parent first noticed it. That's one way to start leaning towards one direction or the other there. Treatment, again, anything you want for itching, for fever, there's no preferred thing. Benadryl, calamine lotion is still fine. Anything, it doesn't matter. All right, one or the other. Steroids, antivirals, controversial right now. Just go with the standard things. This means the itching medicines, fluids, fever control, main things. All right, so after all those infectious illnesses, let's talk about febrile seizures, because one of our triggers for febrile seizures is anything that causes a fever. So this could be a sequelae or a consequence of any childhood infection or illness as a potential. It's a diagnosis of exclusion. So unfortunately, this kid has to go through like a full septic kind of workup, spinal taps, possibly bladder taps as well sometimes, because you have to make sure there's no other cause for this seizure other than a fever. Okay. See, it's a bit of a big business here. Right? Most will be just simple, straightforward one-time events. lasting less than a minute, and that's all they'll have. A few kids will want to have more complex type presentations, repeat episodes, but that is a minority of kids. It's almost thought that febrile seizure becomes a speed bump in childhood that some kids really get just because of fever spike or an aggressive reactive control. It's not built to be really a neurological issue. We're not going to worry about the temperature, we're going to worry more about the rate of that temperature going up. So for it to go up like 4 points an hour is more concerning than the absolute number per se. Now, current research is starting to look at that. That's not current contemporary teaching yet. Current research is looking at the number, but for test purposes, lecturing, things like that, it's still talking more the speed of the rise versus the actual number itself. If one kid in the family has had a febrile seizure, there's a chance that other children that are born in that family or adopted, whatever, that come into the family are going to be at higher risk also. Now, it's actually interesting that I just said that and think about it. But I've always said born into the family, and I follow it up with saying they've not done research to prove it's genetic or not. So I don't know if that statement holds true for adopted kids. But if it's not genetic, what could their explanation be why other kids in the same household are at risk? Parenting, or lack thereof, or failure. You know, if a parent knew how to aggressively control fever for the first kid, they may not learn how to do it with the second kid either. Maybe they're using old medicine dosing sheets, basically when the kid was, 5 pounds lighter or something like that. So maybe more environment. They just haven't done research to show why. But it is proven there's a higher risk when one kid has one than other kids will have one also. All right, how you going to cool them off doesn't matter. Any choice, any method you prefer to use is fine. IV fluid should be part of it because that's going to help as well, like internally to pull them off to absorb some of that heat. And then Tom does the back. I know it was the airport, it's the back back in Georgia. You guys see the airport also? It's the back back there. I just kind of want, like, that's a lot of flights like this. So Tylenol, Advil, doesn't matter. Pick your drug of choice. Teaching points with parents. A lot of times this is one of the most stressful, we call it a parent life-threatening event. It's ATLE. Have you ever heard that? Sometimes I'll be written as the kid's diagnosis, like a pediatric visit, parent life-threatening event. And these are those vague, weird things where the kid's okay, but something significant happened. Seizures are one, apnea periods are another. Those are probably the most common ones. So a lot of times, again, kids okay otherwise, they're having fever. You've got to reassure the parents. Parents see the kids dying, having seizures, right? Reassure them. The kids will be normal. All right, odds are there's not going to be anything wrong with them. They're going to grow up just fine. They're not going to die. Okay, so a lot of parental reassurance is necessary. Fluids and electrolytes. When we talk about these things, we talk about salt and water. Salt and water are buddies. They're like BFFs that hang out, and where one goes, the other goes. So they have talked about both in context here. Our fluid losses, we just talked about the concentration of salt water. ISO means equal parts, hyper means more than, hypo means less than. You're not going to be accountable for things like milliosmoles, how much pressure, things like that, ionic content, whatever. Just equal, more than, or less than. Is it hypertonic or is it hypotonic? That's all wrong. Of course, ideally in this business, we want to treat the source. So if it's fluid loss from nausea and vomiting, let's address that. That's antiemetics, stop the nausea and vomiting. Blood loss, replace the blood, fix the bleeding. If it's burns, you got to get fluid, address the cause of the same thing. We are going to talk about osmolarity and osmolality for just a moment to help us understand fluid shifts. We'll keep it really simple. Consider them both to be the same thing. They're really not, but for us, we're making the same thing. They impart the same concept, if you will. All right, Ryan, go talk about them first. All right. So to talk about osmolarity, we're going to talk about these two containers separated by what? What does that mean? Semi-permeable membrane. Very good. Two containers, a membrane that allows water to move, but the solute, in this case, is salt, it has to stay put. And it's a law of nature that if there's two containers adjacent, if there's an area of higher concentration, it demands that the water come forward to help dilute it to make that concentration equal. It's an irresistible law, you can't fight it. Okay? Osmolarity is basically the force of that attraction, the force of that pull that it has to move. How hard does that water want to get over there? When the difference is large, the force of pull is also very large. So when it's super concentrated, when it's low, there's a huge gradient. The osmolarity is very high between those two. The water really wants to move over to the other side. And it'll do it fast also with a bigger. As it starts to equalize between the two, it starts to slow down until it becomes very, very, very precise and then stops at equilibrium. That's your osmolarity in a nutshell, showing force and pull between these two different concentration solutions. The same content, it's still water with salt content, just one has more water than the other. Okay? And it's any two adjacent compartments. It can be inside the cell and then outside the cell. It can be in the blood vessel, outside the blood vessel. It can be any two adjacent compartments. All right. In general, for dehydration, most adults in the ER setting, 1 or 2 liters of isotonic crystalloid fluid will take care of it. At least it's all so we're talking saline and LR. All right. In most adults, that's all we need to do. All right. Of course, we'll scale it back a bit for seniors, elders, people with heart failure. We're definitely scale that back. There's no rule written in stone about how much, you can do 250 or 500. Just know it's less than that full volume fluid. Kids, 20 cc's per kilo is your replacement or your resuscitation fluid. All right, you're not going to be doing maintenance fluids on kids in the ER. There's formulas for that. All right, and here you go. It's like kind of like DIC. You're doing maintenance replacement for kids in the ER or in your ER too long, and you'd be admitted in those ones. All right, so we're talking just fluid replacements, 20 cc's per kilo for kids. All right, so looking at our electrolytes now, part of this. Hyponatremia, pretty common. Very well tolerated for the most part. All right, sodium is one number you need to know for this test. So what is your normal sodium on your chemistry count? 135. Good. So you guys already know that. All right. So this is your body tolerates this one very well actually, because you typically do not get symptomatic until low 120s. Okay. And when you are symptomatic, the most common symptom is going to be some altered mental status, confusion, disorientation, maybe some lethargy. You can say lethargy for this, because they may not be very arousal, right? Because they're hyponatremia. So, not usually a fatal condition. Treated very easily. We treat it with hypertonic fluid. Okay? Now, here's your mind bender. I'm going to tell you that normal saline is hypertonic. You're going to say, well, no, it's not. But I'm going to say, at the moment your blood is 120, what is normal saline in comparison to blood? It's hypertonic. It's more concentrated in the blood. Okay? We do not initially treat hyponatremia with 3% or higher. That's on admission, that's up on the floor. It's too quick of a change. You're creating a huge gradient by doing that. All right? So for the ER, yes, the book says you use hypertonic fluid. At that moment, you're 120, when you say that it is hypertonic in comparison to blood. So it is you start to move this. Right? We'll say the same thing about hypertension as well too, by the way. So this one is not as common, but it is more fatal, and it has to do with how the cells are to shrink, because it's those two containers. In this case, this is my blood. My sodium is 165. My blood this is my brain cell, and my brain cell has to give up that water. It's a rule. It's a law of nature. It can't resist it. So as it gives up that water, the brain cell's going to shrink. That's going to pull away from its neighbor cell. And up in your brain, those cells are here together with a little bit of vascular tissue, and it's pull, they tear, and leak. So the mortality with hypernatremia is intracranial hemorrhages. Okay, so that's bad. Unfortunately, this doesn't happen that often. Hyponatremia is much more common than hypernatremia. So this one's more fatal. So the treatment here is a hypoosmolar solution. Again, that's when your normal saline. The moment your blood's 160 or 165, normal saline is hypoosmolar in comparison. So we're going to start there. Again, we don't want to start out with half or quarter. That's too much of a gradient. We can actually cause rebound swelling and lysis of cells. Okay. So there's your universal answer for emergency first-line intervention. Normal saline to address both of these to start out with. Okay. On admission, if everybody wants specific orders, that's fine. That's on admission. We're talking the emergency stuff we do in the first few minutes, in the first hour of our patient care. All right, potassium. All right, hyperkalemia is a concern. These are both concerns for the cardiac cycle, because we need to depolarize and repolarize that potassium to each cardiac impulse. With hyperkalemia, you cannot completely depolarize, so eventually the next heartbeat can't come through. You get asystole, so basically talking potassium bolus, a lethal injection, that we're talking about here. Okay. So the findings for this on the exam, you're going to ask about your monitor strips. A common thing is these T waves. T waves are very tall, like a tall spike. They may be taller than QRS sometimes. There's many things you can see on EKG with hyperkalemia. These are just two of the most common, most often referenced ones, and easiest to see on YouTube also. So T waves, and of course that PR interval is longer and longer because what's happening to the heartbeat? The heart rate gets slower and slower and slower as the hyperkalemia goes up. Eventually it'll stop. What you got here is one way to explain about the whole dextrose and potassium insulin. I'm going to tell you the more physiology way, because it's much high in DKA, a little nicer to take people to do this. So to move potassium into cells requires a pump, requires a potassium pump. That pump runs by active transport, meaning it has to have an active energy source to do it. It's not a passive thing, it's not osmosis. It has to actively drive potassium into cells, so it needs energy. What do you think the energy for that pump's going to be? The sugar, the dextrose. All right, that's the fuel to run a little furnace on the pump to make it generate steam and drive potassium. How does glucose get into the cell? Who's the gatekeeper? Insulin. Insulin opens the door for the glucose to get in. Okay, so we can't begin to move this potassium until we address all these potassium pumps and get up and running. They're like a train at a train station. It leaves the station, it's kind of slow at first. It takes a little bit of time to get up to speed until it gets up that full 60, 65 miles an hour on train tracks. That's how these pumps work also. They don't just immediately turn on and start driving potassium into the cells. Okay, they start slowly. It takes a little time for them to start becoming efficient. Okay. So while dextrose and insulin is our standard treatment, we have to have the discussion about calcium. Okay. Not everybody needs the calcium. The person that needs it is one that's already having some cardiac arrhythmias because of the hyperkalemia. Because the glucose and insulin will not work right away, but I need something right now to protect the heart. So the patient's already having some abnormal rhythms, monitor strips, whatever. They need some protection to stabilize the myocardium right now. That's what calcium does. Calcium buys you time until those pumps start running efficiently. Okay. Now, I know a lot of physician providers just give calcium regardless, and that's fine, there's nothing wrong with that. The test question asks you is who needs to have calcium? You need to look for the one that's already having some arrhythmias or some cardiac abnormalities. That person has to have it mandatory. The other person that has arrhythmias doesn't have to have it, but you won't hurt me. You've got to get the one that's having arrhythmias already. This is a little memory tool you can use to remember the drug we're going to use. You remember the phrase C, big K, go down. So big K, means big potassium or high potassium. And go down, of course, wants to drive it down to get back to normal. So calcium, bicarbonates, and glucose. The last two are not lifesavers. You don't need to worry about those. All right. The top four are the ones that are going to get you out of trouble. KX-late is not saving life. Albuterol, yes, it's useful, but it's not going to save a life. In other words, if you go and grab one or two drugs to deal with this, you got to grab the insulin and glucose. Those are mandatory. KX-late will not be on this. We already covered yesterday when you're supposed to get that even, right? Just hard to patient stairs. All right, hypokalemia. So low potassium, same problem here. Again, instead of not being able to depolarize the cell, I can't repolarize the myocardial cell, so that insulin still can't get through. So again, same end consequence, eventually I get no heartbeat. Okay, so it's the same end result. For here, the monitor will lead two findings that are common is these sagging or drooping ST segments. And again, there's other things you may see, there's other more technical. That's again the most common, easiest one to see, that's the one that's on the test. Sagging ST segments. I like that because hypo means low, sagging kind of tells you, hey, it's kind of a low going ST segment. Okay. So treatment here is to replace potassium. That's no question. All right. Do not need to worry about dosages, routes, etc. Except for the one thing, you should never see a total dose of more than 40 an hour. Above 40 an hour does cause cardiac irritability. Granted, if they order 40 an hour, you have to have multiple peripheral lines and multiple central lines even. But you should never see more than 40 an hour. It will cause cardiac irritation. And PO potassium does not save lives. We're not even talking about that. This is just IV potassium we're talking about. Right? PO is not for now, in fact, that's tomorrow. All right. SIADH, inappropriate anti-diuretic hormone. So inappropriate meaning done incorrectly. Anti-diuretic, well, if something's a diuretic, it makes you do what with water? Get rid of it. So anti-diuretic makes you retain it. You think about, is there a possible reason your body wants to secrete this in a useful sense? Correct, that's one trigger for it. Yeah, but why would our body want to retain water? What purpose is that? Okay, times of low hydration status, times of hypotension or hypovolemia also, we increase our preload, keep blood water on board, increases your circulating volume, things like that. So this is being done when it's inappropriately done. This is commonly a sign of a pituitary tumor, because the pituitary releases ADH. Oh, by the way, the drug name uses vasopressin. I'm sure you've heard that before, right? When we use vasopressin. And coke, we use it for a couple reasons. One is inotrope. Another reason is it's going to help increase your, it's not going to immediately, but eventually it actually helps build up your preload also. And another form is called DDAAP. Have you ever heard of that? What that stands for? Desmopressin. Childhood problem. Bedwet. Oh, that's interesting. So basically giving them a drug form of an antidiuretic, what does that make them do? Retain water, which means there's less pee in their bladder, which means they're less likely to have bedwetting at night. Interesting, right? Cool. All right. So anyways, so this might be a pituitary tumor, and then, you know, if that's the case, they'll minimally do surgery, things like that. But what we see as a result of too much fluid is the low sodium. Now, the actual molecules of sodium are the same. It's the percentage that your brain responds. Your brain says, hey, I'm hyponatremic. The brain is stupid. It doesn't know why. It doesn't know that it's a fluid problem. The brain still sees it as a low sodium and may have the symptoms of that confusion, disorientation, or whatever. We as the clinicians need to recognize it's a fluid problem and deal with that fluid. Okay, so on your lab test, you'll see hyponatremia. You're probably not doing all these osmolarity tests in the ER, I get that. I want to tell you though, the serum osmolarity, we do that sometimes in the ER. At least that tells you it's a water problem. Because if that serum, the blood osmolarity is low, that means that you're very overhydrated. There's too much fluid on board, that's why the osmolarity is low. The other ones, they might do on admission, the hospitals might look at urine osmolarity, things like that. But in the ER, and anytime you think a person's hyponatremic, you don't know why, check a serum osmolarity, because if it's high, it tells you it's a fluid problem. Because you can be hyponatremic from either losing salt or too much water. So at least in this case, that one test has fluid. So we've done this and we decided, well, it's too much fluid on board. What do we do? Well, we need to address the sodium and the fluid. Because our brain needs a sodium problem. So I start some normal saline, just like hyponatremia. But at the same time, I also start giving some lacing. So I'm trying to work both sides of that equation by adding some salt, and taking away some water, and trying artificially get those things to equalize out. Right? And we're just going to do the starting treatment for this. This person will be admitted, and do further workup. You won't know in the ER if it's 2 or 3 treatments or not. They're going to look for the cause, and hospitals do all their fancy other testing and things like that. But for us, normal saline plus laces, trying to work both into that equalizing equation. You don't need the doses, by the way. Hey, we only talked about 4 or 5 numbers each now. That's pretty cool. Endocrine, so our endocrine glands. Addison's disease, that's a chronic disease state of adrenal insufficiency. We're going to talk about Addison's crisis, that's the emergency problem. Okay? So just for a moment, we'll cover the chronic disease, you can understand the acute phase. The chronic disease state, the cortisol production is blunted or inefficient. Cortisol is produced by the adrenals. What do you need cortisol for in your body? And two of the big things it does is it regulates fluids, 3 things, fluids, sugar, and blood pressure. Okay. Matter of fact, to obligation, if you ever met that young girl who has hypoglycemia or all these fainting spells, if they actually pursue like that, like work up in a primary internal medicine setting, they're supposed to check cortisol, and some people are cortisol deficient. But Addison's disease is that chronic state. Addison's crisis is when you suddenly go into cortisol shutdown. In other words, it's suddenly taken away for some reason. Okay, and you actually become very extremely profoundly hypotensive, maybe unconscious, hypoglycemic. Right? How could this happen to someone that doesn't have Addison's disease? How could someone go into an Addison's-like crisis all of a sudden? How could someone suddenly not have cortisol in the body? Followed by what? They've got half the answer right. They're using long-term steroids, which is suppressing the cortisol. Prednisone's replacing it. What's the other half of the story? What's suddenly happening? They abruptly stop using exactly. Their bodies become dependent on the external steroid source. All right, that's one reason why drugs like that just taper them off slowly. Now, because this patient may present obtunded or unconscious or altered, you may not know that history. You'll just treat what you see. You'll treat the low blood pressure, fluids, and pressors. You'll treat the hypoglycemia with dextrose, whatever. You know, if the exam wants you to know, they'll tell you the patient recently stopped their prednisone, and that's pretty much a common scenario there. Or there'll be a situation like a bottle of prednisone is still full, and they filled it 2 weeks ago or something like that. They'll give you that info there. But once we figure out that's what it is, it's simply IV hydrocortisone, also called solucortef. And that's a cortisol analog, and they immediately start to respond. You don't fix them immediately, but they immediately start to improve. They're going to be admitted, they'll be in ICU. They got other things to do. But basically, it's like cortisol suddenly becomes absent, deficient. HHNK, they're actually changing this name, not for exam, but in current teaching of medicine, commercial teaching. They're changing it to something to me, no, I just read the other day, I didn't remember it. It still means the same thing, but they're changing what it kind of implies as well. But for the exam, we're still going to use hyperosmolar or hyperglycemia. Or HHNS maybe or something. Yeah. But it's still got the same issue, the same description, it's got the same issue, just different name. So they're hyperosmolar. What does hyperosmolar tell you? Are they diluted or dehydrated? Dehydrated. They've lost control. Hyperglycemic, you know what that means, it means a high blood sugar. Non-ketotic, that's one of the defining characteristics here. They don't go into ketosis. Okay, they still have a little bit of insulin in their body. Okay, this is predominantly seen in our type 2 patients or our adult onset that are not completely insulin absent. They still produce just enough insulin. They go into their acute phase, they don't resort to all that fatty acids habits, so they do not become acidotic. All right, so this is more often the emergencies of type 2 patients. And sometimes the patient does not know that they're a type 2 patient yet, but they've been walking around the blood sugar 500 for the last 6 months and working about their fatigue and peeing all the time. And now suddenly pneumonia comes along, which suddenly puts them over the edge as far as their metabolism goes, and now they wind up in HHNK. All right, so as far as the labs go, their pH will be normal. They're not acidotic, so they're not in full ketosis. All right, sugar, generally over 500 or 600, because again, this is a type 2 patient. They generally have elevated blood sugar anyways. Even if they're fairly regularly controlled with their doctor and managed, they're probably 200s on average days on their blood sugar. Okay? So when they go up, they got a lot more room to go up before they get in trouble, as opposed to a DKA patient. There's not a lot of tolerance there. If they get pretty sick, they can too high. Ketones are negative, but if they are positive, so it's very, very slightly, but it's not enough to change the pH. Now, treatment for both of these is pretty straightforward and similar to start with. You need to give them fluids, because both HHNK and DKA are hyperglycemic, they're having an osmotic diuresis, they're profoundly dehydrated, both of them. They both need massive amounts of fluid to start, at least 1 or 2 liters, unless there's something that you can tell you to be careful, like heart failure or a really, really old person. Lots of fluid to start. Both patients are going to start giving insulin. For this exam, it doesn't matter how you do. You can put HHNK on insulin pump if you want. That's fine. You run on your IV pump. You can do that. You can do both. It doesn't matter. You can put the DKA patient on pump or do it both. It doesn't matter. That's not the test question. The test information is fluids and insulin for both of them. Okay. One difference is who gets potassium and who doesn't. For HHNK, they don't need potassium unless it goes low. Why? Not only that, but remember what those potassium pumps run on? Sugar and insulin. Does HHNK have plenty of sugar for fuel? Yep. Do they have some insulin in the body still? Yes. So some of their pumps are still running. Okay, so it's not like they're a complete shutdown. So we can wait and watch with this patient. Right? In contrast, jumping ahead to DKA, you are going to give them potassium regardless of what their number is, because their pumps were completely turned off with lack of any insulin whatsoever. So DKA is our emergency more likely with our type 1 patients, ones that have no insulin in their body natively. Meaning, as soon as they go into trouble, they start taking fatty acid metabolism immediately, which means they will go into ketosis, they will go into metabolic acidosis, and they will be very, very sick. That's one of the reasons why ketones floating around, makes you nauseous and stuff. So potassium will be elevated. Why? Why would potassium be elevated? It's simpler than that. What do they not have in the body? They have no insulin, so the pumps are not even on. So I guarantee you by the time they're sick, that potassium will be high, regardless. They will be acidotic from ketones, and ketones, acetone means the same thing. So if you measure acetone, it'll be like plus, plus, plus. If you measure ketones, it'll be like 80 or more. All right, so again, fluids first, and insulin until the ketosis resolved. We discussed this yesterday in our hyperemesis. What happens when the ketones go away? It tells you to do what now. You'll finally get enough insulin in them to use the glucose so they can use carbs rather than fatty acids. So we start backing off the insulin when they start to make ketone negative in the urine. Or if you're drawing acetone, or acetone negative. And we'll start giving potassium at the high end, even higher than the high end. You're pretty much going to give them potassium regardless, because you know they have insulin in their body. You just dump a bunch of insulin in them. So suddenly they start firing up all those pumps. And the same analogy that train takes a while to get started, it takes a while to shut down. You just don't stop a train right at the Amtrak station from 60 to 0. All right? When it starts to slow down, it takes a long time. So if you're waiting for potassium to go back to normal, and then start treating when it's low, you can't catch up fast. So you do start getting potassium early, because pretty much you can drive it all from the bloodstream into the cells.
You're also saying that the HHS are starting the glucose once, or you're starting like a dextrose solution around like 250 to prevent the
Not right away emergently. The main thing is to start using the glucose that's circulating, and to address the diuresis and profound dehydration. So those cells are so dehydrated they're not functional. Now we've got to get back to the metabolism. Some of those patients, if they can take, you can start dextrose. It's not going to be the first line. Yeah, you're not incorrect in saying that I'm starting dextrose on them, but you're not incorrect about that. It's just not the first line. Hypoglycemia is the most common endocrine problem, but you don't deal with it as much because we get thanked for it. EMS, they go out there and give us the dextrose, they sign away. Yeah, it's the right thing to do. Different discussion. So that's why you always see that much. Your medical definition is less than 50, but not everybody has symptoms less than 50. Physiologically, between 20 and 30, you will have a problem. Okay? Cells will stall and die. Somewhere around 20 to 30. But 50 is what we call medically defined as. There's no one answer for it. Emergently wise, we treat it with replacement dextrose or glucose, and we have to, of course, reassess to make sure that it's staying up. Different providers will get different parameters as far as it drops twice in a couple hours and hit them. Different ones use different things. That's not for us to worry about. Just realize that we need to find out the underlying reason why it was low in the first place. Was it too much insulin, not enough carbs to offset it, or they use some profound illness causing metabolic abnormality, whatever. I will say this: the most common patient I've admitted to this has been an older female, like a senior, who's on Lupitrol. Lupitrol has such a long half-life that even though on admission you're not taking it anymore, from that point forward, it takes days for it to eliminate out from their little bit of renal insufficiency they have as far as clearance goes. And a handful of times I think it's always been that Lupitrol, which is just a long half-life. So we've already covered the thiamine. What is thiamine protecting from happening? If I'm going to give dextrose to somebody, I need to consider thiamine. That rebound encephalopathy from thiamine. So This is part of the discussion we have with our alcoholics and the pack needs. All right, kidney failure. Three types of kidney failure. We're talking acute. All right, we're not going to have a chronic discussion in this class. That's not really what it is. Acute renal failure, pre-renal, intra-renal, and post-renal. It just describes where the problem is getting the blood to the kidney. Pre-renal, something most common cause, hypovolemia, dehydration, fluid problem. All right. Intra-renal, these are some surgical or medical causes that can fix and treat it, like a one-time deal. Fix these things, and good to go. Post-renal common things, kidney stones, probably the biggest one, because it's obstructing the flow, and it's causing hydronephrosis, and swelling large. Those three in the middle are the intrarenal causes. They're not as uncommon as you think. Glomerulonephritis. This is the reason we treat strep throat. One of the reasons we treat strep throat, actually. Strep throat actually goes away by itself. Your body can fight it. We treat with antibiotics to prevent this for one. There's a post-streptococcal nephritis you can get, which causes kidney damage. The other one is to prevent endocarditis-like issue, like a rheumatic issue. So glomerulonephritis, treat the infection. Tubular necrosis. What drugs cause kidney damage? If you ever did med surg, you might have peaks and troughs. Vein, gin. Okay. Those are probably Tobra, those are probably the most common. Those are mice type drugs. Okay. So if that's the issue, you stop that medicine, find a different medicine. And if there's renal artery stenosis, they'll go in and do a heart cath and say, go to the heart, they'll go down to the renal artery and go on there and dilate or where they do to open up that stenotic area, which reduces the kidney. So those are things that you can fix at one time, they're not a chronic issue. How do we measure kidney function? The BUN and creatinine, the normal numbers are 20 and 1. And if it's acute renal failure, typically they tend to go up almost in proportion, so like 42, 60, and 3. The chronic or long-term renal failure we're seeing, you see the BUN stay fairly steady, you see the creatinine starts to rise by itself, 1.2, 1.4, and so on and so forth. So in the ER acute setting, we'll probably see that acute failure with one proportion. All right, there's not a one medicine dealing with kidney failure. I just put a list here. It's kind of like some of the topics we discussed. You need to look at the information given as far as what the cause is, and then treat the cause without it. If you just took a shot in the dark and you had to say what the most common acute renal failure issues with ER, pick IV fluids. Probably pre-renal, dehydration, hypovolemia from blood loss, or burns, or something like that. That's your most common one at the end of the day. Okay. And even then, if there are acute renal failures in rhabdo, what's the treatment for rhabdo? Fluids and lots of it. All right, rhabdo is more of an intrarenal problem. So again, you're already playing the odds on that. So I'm starting with the bolus IV fluids is a good choice for acute renal failure, nothing else. All right, Graves' disease, the thyroid gland. The thyroid is basically like your energy control center for your body. So hyperthyroid, like a hyper energy state, where see thin skin, hair follicles are not mature, so hair falls out, they grow fast. The bulging eyes, the exophthalmos, you'll see tachycardia possibly, all those signs of overactive metabolism, basically overactive energy. We do need to look at how we tell if they're in a thyroid crisis or storm, which is our critical condition of this. The thyroid is so overactive that it's causing cardiac compromise because it's such a tachyarrhythmia, the heart can't fill up with blood, attention get hypotensive, it's going to impact the failure. Okay? So TSH is all we need to at least tell us if that's the problem or not. And the thing with TSH, it goes to the opposite level, the opposite way which the thyroid level is. So TSH is secreted by the pituitary gland. The pituitary gland is the boss of the thyroid. If the pituitary senses there's not enough thyroid hormone circulating, it says, hey, Mr. Thyroid, get up and go to work. So it's kick and beat up the thyroid glands and get off your butt. So the thyroid stimulating hormone is high when your thyroid level is low. And the opposite is true also. The pituitary gland says, hey, there's way too much thyroid hormone. You're working too much. It starts to pull back the stimulating hormone, and the hormone, the TSH, goes to low in a hypothyroid state. So if we do use the TSH as an emergency test, not always the first line one, but if I've excluded all the other causes of why something's happening, it's heart rate of 150, 160, I would go to fluids, I would look for fever, I look for electrolyte abnormalities, things like that. At some point, I might need to look at TSH, because that treatment would be completely different. And if they're actually in a new onset thyroid type crisis or hypothyroid state, I need to deal with that. And I might at the bedside see this, what is it called? Goiter, enlarged thyroid. Some people it's, average or medium, some people it's vertical or big like that. So when they're in crisis, they need to shut that down, okay? It's causing cardiac compromise. All right, now actually I should probably someday reverse this and put your beta blocker on the top line there, because that's what you can use in the ER system. Metoprolol, low pressure, you'll get that heart rate under control, slow it down. Realize this, the thyroid level in the body, not the TSH is like 0 in this patient, okay? But their thyroid hormone is still high. The beta blocker does nothing for that. That is still there. I'm just artificially trying to get the heart rate under control. The thyroid still has to be dealt with on admission. On admission, your endocrine, your ENT, or whoever can manage this, they're going to give PT with potassium iodide. It's actually a chemical shutoff. That's what it is. Okay, it's like flip the switch to shut the thyroid down. Chemical. All right. Emergently, though, we use beta blockers to control. On admission, they use another tumors themselves. And on admission, they're going to figure out why it was overactive. Was it cancer? Was it nodules? Was it hypoplastic? What was the thyroiditis? They'll do all that on admission and decide what treatment for it. Our goal is the beta blocker, low pressure, slow the heart rate down. We see that TSH is like 0, super low. All right, some of the general stuff. Allergic reaction, we're going to talk a little bit more about this in the shock section, because this is one of our distributed types of shock, but just a quick overview. True anaphylaxis, they're having peripheral vasodilation. Histamines are vasodilators, and the lungs histamines are constrictors. So you get this low blood pressure, you get the shortness of breath, wheezing a bit also. Okay. Treatment has to be geared at the cause. So even though we use medicines like epinephrine and anaphylactic shock, the epi is just getting us some better cardiac output. It's not actually addressing the reversing histamines. You've got to give antihistamines as part of the treatment for these allergic reactions. These are still some common things that are out there. They're starting to research now about the whole penicillin allergy, finding that a lot more is over-reported than is actually true allergy, because a lot of the reports are just, oh, mom told me I was, but they don't know why or what made the parent think they were when they were a kid. Now they're 30 years old and saying this. So they're starting to reinvestigate that. But what it is, it's still one of the top things on this there. Hymenoptera is the name of that whole family of those flying, stinging, biting type insects. So bees, wasps, yellow jackets, hornets, whatever, because they all have a similar antigen that can trigger these reactions. So we just call them all Hymenoptera. That's one of their family names. So medicines, epi. You guys change to any epi-IM instead of sub-Q? Okay, so these are considered. Yeah. What do you think the rationale of this? IM. Maybe possible. It's actually they're actually trying to avoid a complication or if you give it sub-Q, there's a potential that it can do what? Constrict all that tissue, okay, and epinephrine just gets stuck and held in the sub-Q space and never get into the circulation respectively. So some schools of thought are saying now give it IM, we're giving it to a much more vascular tissue. Even though the epi can constrict some of the smaller capillaries and arterioles, you're giving it still to a vascular tissue that's more likely more to pick it up. Just a different school of thought for different things in different places. So that's one of the rationales there. Is that sub-Q may actually stay there long and not actually get into the mainstream circulation. There's no right or wrong in this test, though. I just want to tell you what you're doing. For the allergic reactions, the albuterol is not going to be lifesavers between the epi and the Benadryl for the most part. Steroids also are not the lifesaver. They're more for tomorrow, basically. Treatment cause for the antihistamines. Fibromyalgia is, of course, not really an ER problem, but it is a comorbidity that some of our ER patients have that might affect other things we do for them. So it's just a basic understanding about it. Idiopathic, remember, doesn't mean it doesn't exist. Idiopathic means you just haven't identified a consistent cause. Okay, so that's another one of the discussions. But there are criteria for it. It goes back to muscles, having sort of trigger points, and there's actually diagrams and there's criteria for physicians to make these diagrams. They just can't slap it on something. They actually have to document certain areas. And there's several of them. It's like 12 or 14 they have to have different areas of it. But treatment for these patients, this is similar to irritable bowel syndrome. There is evidence that proves that antidepressants make these better. And again, don't know, which comes first, the chicken or the egg cases, but all I do know is science says from antidepressants, less episodes, less severe, better quality of life. So that should be something you see on a medicine history when the patient comes in and they can tell you all the medicines are on. For acute, you can use analgesics. They don't want to use opiates though. Standard medicines, Tylenol, ibuprofen. I know they seem like they do nothing, but for people, some people these medicines actually do work out. I'm dealing with a toothache this week, and 600 Advil 3 times a day is actually keeping it pretty quiet. So it actually works. That's what my dentist says I get. Muscle relaxers, but notice there's no opiates there. Ray's syndrome or Rise syndrome. This is caused when aspirin damages the liver. Normally, this should not be a problem, but there's something about when a child is having a viral illness, there's something about how it exposes the liver to the aspirin, causing it to become toxic and damaging. Okay, so when you say what causes Rise syndrome or Ray syndrome, you have to say aspirin given during a viral illness. That's the two parts of that answer. Because on a good day and a normal day, a kid should take aspirin would be just fine. There's something about that viral response. We don't know, does it start to be successful the day of the fever of the virus, the day before, the day after? They don't know exactly when. So the best thing to do is just not give a child aspirin at all. But if this were to happen, it's basically just like a liver failure patients. You get all those elevated liver numbers, biliary pneumonia, possibly the INR going, possibly hypoglycemia, things like that. All these things can go wrong with liver, end-stage liver, can still happen like this was on. So the first thing was obviously stop the aspirin. The kid will be admitted to some pediatric critical care setting. And it's basically to treat the symptoms until the liver heals. Okay? Treat the sugar, treat the fluid imbalance. Treat the, when you treat hyperammonia with, what medicine? For liver patients? Lactose, right? Smells like vanilla. All right, so the safest thing is just not give because it doesn't help you start talking baby aspirin, right? It doesn't help it. It's still called St. Joseph's children's aspirin. You just need to get rid of it all together. All right, hepatitis A, B, and C. These are all liver infections. They're all going to have the same viral response. The malaise, the myalgias, the low-grade fevers. That's similar with all these. Even HIV, by the way. All viral responses initially to initial insult. Okay. A few things to keep type A, B, and C separate. Type A is known to be an oral fecal route of transmission, so associated in communities or environments where there's some sanitation issues or poor hand washing. But sometimes you see like in second and third world countries where there's lack of adequate sanitation or public utilities, you can see that. So that leads us into a possible test question that we've seen a time or two about can you get vaccinated for. Yes, you can. You can actually get vaccinated with IG, which is what? Antibodies. Okay, so you're going to protect them immediately. Now, the test question is, you just can't get your shot today and go tomorrow. He says, Mark, yesterday you told me you need protection. You do, but you don't get enough protection just with one immunization at a time. You need a couple. And that's the test question. You just can't get it today and go tomorrow to Haiti or wherever country you're going to. It takes 2 doses. Hepatitis B exposed. We only need one blood test, one blood sample. We're going to look at surface antigen. It's written just like that, with small letter S. And surface antigen appears anytime a foreign invader comes into your body. When something foreign enters your body, your body sends out a bunch of white blood cells, and one of the little squads or platoons, their only job is to go look at the foreign object and see what it is. And they take a picture of it, and they wear it on their surface. Or they like sketch a picture, however you want to say it. But they carry on their surface a coating, and it's an antigen, and it's a mirror image of what they saw. They go back to the immune system and say, hey, have you seen this before? This picture I just took. Your body's seen it before, then it goes and pulls the recipe for antibodies and starts making them. If your body hasn't seen this before, it uses this as a template to start building a recipe for antibodies. Okay, so every exposure of surface antigen goes up because its job is twofold: to be a messenger as well as to actually have a picture. So every exposure. So if you get a needle stick, of course, what's the best person to test if you get a needle stick? The person's needle, all right? So this is giving a test scenario that we're going to give you the situation that it was a needle found in the room from like 4 hours ago. Several patients were admitted out of that room, as it is. So you're going to get tested. If you're going to draw one blood test, they're going to draw just the surface antigen. Because if it's negative, guess what? Nothing foreign came into your body. Okay, the surface antigen only goes up if something foreign is there. Now, if we do second level testing, so your surface antigen came back positive, meaning you had exposure to something. Now we're going to do a second blood test, and we'll see, do you have antibodies already in your system? If you've got antibodies in your system today, did you build them today? That then tells us that you actually have been exposed before, built up some of that immunity from before. So we only need one blood test. Now, I know if you've gone through the needle stick protocol, I've done it twice. They're going to do like a whole bunch of stuff. Okay? They're going to do like a bunch of questionnaires, surveys, lifestyle, other risk factors. We're going to draw several tubes of blood, etc. In the perfect world of textbook medicine, one exposure, all I need is this one test just to start the ball rolling. Okay? Now, all this said and done, if I get sick from that needle stick and I get hepatitis B, okay, I don't care whether you had a positive antibody titer or not. The fact is you got sick, because you not have enough protection. Guess what you're going to get again when you get well? You're going to get your hepatitis shots again, because obviously it didn't work on the first time. It's by definition, you got sick. Yeah.
So the H4 antibodies, though, if they do test